Hey, good afternoon or good morning, depending where you are at. Michael Campbell and for us, I think it's evening, but welcome to the second event in a series of educational webinars that Michael Campbell is presenting on and I'll be hosting. Thanks for investing your time with us. Today, we're really going to focus on data quality as it relates to securing clinical data. We're at a time where clinical data is really becoming the necessary currency, and health plans are still challenged to really optimize their clinical data. So we're kind of introducing a couple of concepts that we hope will provide some good insights for your organizations. My name's Michael Blumenthal. I've been working in healthcare data quality for close to 30 years. I'm an investor and advisor to Velox, and I'm going to pass it on to Michael Campbell. Thank you.
Great. Thanks, MB. So, folks, in today's 30-minute session, which is, as MB noticed, is really the second webinar in a series that he and I are doing on clinical data operations, really specifically targeted towards health plan quality managers. Today, specifically, in addition to a component of data quality, we're going to focus more broadly on data management. Our first session, prior to this, we provide an overview of the current healthcare market and data operations. And it turns out, we found out, incidentally, it was like a breakaway hit in Argentina. And Will, what was the other country it came out?
Zaire.
Yeah,
Is that still a country?
Right, like a lot of fans in Zaire of data management and data quality operations. So we also, if you would like a copy of that, we do have that recording. It will be available to you as well in addition to this one. But in the meantime, what I thought it would be a good idea is to kind of provide an overview of that session here so that everybody can kind of level set. So we addressed in that session revenue pressures in the healthcare market, really notably the significant loss of Medicaid eligibility due to redetermination cycle requirements. I want to give a shout out to Lauren Diuto. I'm a big fan and follower of hers on LinkedIn, and she published what I think is a very clear and insightful strategic analysis of our industry and where it is right now, what it needs to do to move forward and modernize. And that report is called the System Overhaul in Motion. It's really foundational to my thinking on where we are and really how I formulated these ideas about where data management, and particularly in medical management and clinical data operations, can provide really strategic guidance as we're navigating these threats. Okay, so another threat. Guys, I don't know if it's just you or me or all of us, but I'm not following what this Medicare Stars bonus threshold prediction calculations. For me, it reads like some exotic form of non-deterministic physics. So if you can help me out or help all of us out, and you've got an explanation of really quick and easy way of understanding thresholds and predictions, please share. There's a need for it in the industry, no doubt. Another thing that we've observed is that we are experiencing what I think a lot of analysts call, and I'm just going to paraphrase, poor forward visibility on government reimbursement rates, or in other words, who knows? That's one that we're just going to have to leave as a known unknown at this point. And then to top it off, the revenue pressures also include consumer price resistance to increasing premium increases. So that's fire red. We can't really touch that, and why? I think we all know that employers and consumers are absolutely tapped out, especially in the health insurance market. And then it gets better. We also would like to add the bottom line perspective. And in here, we address stressors on operating margins, including the higher utilization rates, which we're observing, medical cost inflation, and increased compliance costs. Now, in regards to compliance costs, we know that we have right now coming soon the CMS ASTP data interoperability requirements, including the prior auth final rule 0057-F as in festive. And that's going into effect it's in 2026. So that's 2 weeks, guys. So we have the first phase that's due in 2 weeks, but don't panic because Margaret's going to provide a link to that lengthy CMS document in the chat, and we've got you covered. And again, you've got 2 weeks to prepare for it. So that's a summary of the strategic threats that we're observing. Notice I didn't mention budget cuts, payer consolidation, or a number of other areas where we need to address.
What about AI?
Yeah, thanks, Will. AI. I think we decided we were going to ixnay on the AIAA, but we're going to put that 800-pound gorilla in the corner for just a while because we know that's one that we're all very closely monitoring in our careers and in our industry. Okay, so threats really provide context to opportunity. And the good news is many of these domains that I just highlighted earlier are ones that we can really positively impact from a medical management standpoint, including quality reporting on that quantum physics space of MA stars, member engagement and care coordination, utilization management, better provider contracting, as well as compliance with some of those stricter, more technical requirements that also have higher verification frequencies. Okay, so before we get more into clinical data operations, I would like to just kind of take this time to, I'll say, share an admission together. I think it appears that we appear to have a codependent relationship on administrative claims. And let me give some rationale for that. I think we can acknowledge that we are really over-reliant on administrative claims for our work. And I think it's true that we like the highly structured data. We like that it's highly validated. But much of that has really only come about due to the 1996 HIPAA federal regulations that mandated compliance with the ANSI X12 data standards. Just note, these standards have driven down data transmission frequencies for our administrative claims from providers to health plans down to about 24 hours or even real time. And we're incidentally finding ourselves in this same equivalent moment in our industry as users of clinical data, where there are federal regulations that mandate, in this case, not ANSI, well, it depends on your, ANSI is actually a regulatory agency for HL7, but HL7 governed FHIR standardization in clinical data exchange. So we also know about administrative claims that they're really data attributes and values that are more contextualized for payment and benefits, not for medical management. And then one other limitation for claims in particular is that there are just a number of different payment business rules that really embed latency into the data exchange. So it's not all the claims' fault, it's just the rules that they're required to follow. Now, just to add a little bit more illumination around the limits of payment or use of administrative claims is it's actually adjudication. And we're pointing it out there. We're looking at adjudication at 7 to 14 days. And yes, adjudication adds the most latency to that data lineage as we move from the authoritative source to the target use case repository. So it actually comes out around an average of 16 days. 16 days. You know, that's not really that great. And I think we can do far better than claims and certainly better than 16 days. But first, we really need to get some things cleaned up in our house, in our operations for clinical data operations, such as we really have a very limited adoption of clinical data formats like CCD and FHIR. We also have, I've observed, I should say, rather low maturity in data governance programs in the payer space. And then finally, we have a lot of maybe undefined or inconsistent data quality metrics, frameworks, and tools that we're using for clinical data operations. But there is actually a really strategic way that we can start to optimize and standardize our clinical data operations. First, we're going to prioritize standards-based data sharing channels, particularly those that are direct to the authoritative source. And that will really allow us to improve access, but also reduce our dependency on intermediaries. And we're also, by ensuring this compliance with FHIR as an example of de jure formal standard, we can also start to get some ROI as we move towards that more data-driven clinical insights. Now, strategic operations also require, like I mentioned before, we have to have a defined data governance framework and management tools, which are really these, I'll say, structural backbone for accountability, compliance, and efficient resource allocation. And then multidimensional data quality standards and tools. We really need rigorous evaluation of data quality while we also can enable the use of data quality benchmarks. Okay, so I mentioned this slide actually in the first part of the series, but I want to reiterate it again. In fact, it'll be kind of a theme that we'll want to make sure we keep hitting throughout the series, that it's really not an option now to optimize your clinical data operations. It's really a strategic imperative, especially if you want to survive and ultimately thrive in this regulatory pressure and competitive demands. But I want to be clear about data management. It's not really exclusive in IT responsibility. It's really everybody's responsibility. And I think even more so, especially for medical managers, because you are really the subject matter experts and the business users that best understand the context of your clinical data usages. So let's skip over now to data management. So some of you may be familiar with DAMA International, and they provide a lot of frameworks and definitions, and they're quite well known in the space as an open source consensus-built standard for data management. And their definition of data management is actually really quite generic. I'll just read it out loud. So the development, execution, and supervision of plans, policies, programs, and practices that deliver, control, protect, and enhance the value of data and information assets throughout their life cycles. This is actually really useful that it's so generic, because really all domains of organizational management require data management. And this is really including business, education, healthcare, of course, research, and government. Please, government, start to implement some standardized data management. But I also want to make an important point here, really specifically to us in the space of healthcare. I think of what we're doing in our commerce really based on human health and wellness, including life and death. And our domain, I think most especially, more than any other domain, really needs to embrace a comprehensive and accountable data management standard. So when it comes to data management frameworks in general, I really don't think we can do worse than DAMA International. It's the most well-recognized open source standard out. So in an iteration of it, I don't want to say the current one because it does evolve over time. There are actually 11 knowledge areas of data management. We're not going to cover all of them today or really even in the series, but we will touch on data governance, data quality, and because fire is just fire, we'll touch as well on data modeling and data exchange throughout the series. Will, did you notice that Dhamma wheel kind of looks a little bit like the Buddhist Dharma wheel?
I think it does. Namaste.
Yeah. Namaste. Well, it may actually be not just a path to data management. Who knows? It may actually be a path to enlightenment. That will be a big TBD. Okay, data governance. So at the hub of the wheel, this is really what establishes the structure or the framework, as well as the governance roles and the policies assigning authority and accountability in the management of the data assets. So that's core part of the overall data management paradigm. Now, there is this kind of legacy view of data governance, but there's also now a more demand for what's more of a modern data governance, which is really critical because as this Gardner's article or analysis by Adaptive Data and Analytics determined about 80% of organizations are seeking to scale digital business will fail because they do not take a modern approach to data governance. So I want to give just a brief kind of view of what modern data governance can look like. This is according to Euderica. This is the features that they consider to be kind of required for a modern data governance. And you'll see here listed the role-based access controls and accountability for data user roles, the use of data catalogs to inventory data assets, provenance and lineage metadata for data sources, integrated and scalable audit and compliance functions and features, and then finally, advanced monitoring, analytics, and reporting tools. Okay, so let's talk about more specifically about the roles under a data management, data governance paradigm. So at the top, we're going to move from, let's say, data management more into the IT layer, so more from business down to IT. In the top, we have the data owner. This is usually the senior business manager that takes that top-down approach or view of data management. And they're really responsible for governance and accountable for the ensuring that the organization's data assets align to its business objectives. And then under the manager, we have the data steward. And this is really for many of you participating, is really more likely where you will fit in. You are the subject matter expert in most cases in medical management. And you really focus on the data, the data about the data or the metadata, and then the lineage, where the data came from, where it's going, and what was done to it along the way. And then finally, the data quality to really make sure it's usable for your responsible use cases. And then, like I said, as we start to transition into more in the IT roles, we hit into the data custodian and the data administrator roles. And often these are the ones at payers that tend to somehow get merged together. It depends on the size and the complexity of your data operations. But it's really important to indicate that these users who fall into these two roles, they are not just acting independently. They're really responsible for ensuring that those top-down business rules, requirements are distilled correctly to their environment, where they then instantiate that and implement it and manage it correctly, say in the data models or in the databases, and make sure that they're executing according to those top-down requirements. Margaret, this is where I believe we have the poll. If you can distribute that so that we have individuals have a chance to respond to that.
Just went out.
Okay, just went out. Okay. Let me see if I can find it, see where, there we go. Okay. Okay, we'll let that one go. And then let me know when we're done there. I think we'll skip to the next slide and let me know we can pull that back in. Okay. So I also want to talk about data quality. We'll kind of end around data quality. So this is an area that we will cover in great detail in the webinar, fifth webinar in our series, but I want to take this kind of time to just give an overview, a high-level overview of data quality. So let's just start with the intended use categories and hierarchy. So as we're moving from this bottom left with operational uses and we move bottom to top, we really start to increase the criticality of the data quality. So we're at the bottom, we're just dealing with operational issues like finances and workflows. Not to say data quality is not important, but not as important as we move into, say, the second, third, and fourth layer, where we start to talk about individual patients. And these are, obviously very often, like I mentioned earlier, life and death types of decisions that are made for these individuals. And of course, the data quality is of the utmost importance in those circumstances. If we move and we start to aggregate individual patients into patient groups for, say, population health and quality management and reporting, we start to basically inherit the data quality from the previous uses. And then finally, at the top of that list or that hierarchy, we have scientific studies. And this is where we have, for example, even are building clinical practice guidelines, peer review, and then potentially even implementing. So again, there's that inheritance as we move from the lower tier to the top tier, and any data quality issues that are prevalent in the lower tier will certainly be inherited into the upper tiers. Another area that we'll go into much more detail, but I want to touch in here, is that data quality frameworks. We mentioned about the use of standardized data quality frameworks. There should be a set of dimensions that are included in that framework and how they're defined and certainly how they're measured and instantiated into your organization. There's some kind of familiar favorites that we recognize with completeness, timeliness, and accuracy. But I want to give a special shout out to really my favorite, which is kind of more a more modern data quality dimension, and that's auditability. I think it's really moving up in the ranks, partly because it really focuses, like I've mentioned earlier, on traceability. So what's the data provenance of the source, and what's the lineage as it moves through the various data systems before it gets to the final use case. Now, this is really useful when it comes to compliance audits, but it's also really useful because we're thinking and observing more data pipelines, so high velocity, high volume, high frequency data channels, and we need this kind of auditability dimension to really audit each of those individual channels and scale those audits across channels. Okay, and then another example of a data quality framework that's more explicit, not just kind of a template like I showed earlier, is PIQI. This is the Patient Information Quality Improvement Framework, which is a healthcare specific open source data quality standard that's actually under ballot right now at HL7. This one, it consists of 4 dimensions. They include availability, accuracy, and conformity, and plausibility. These are, you'll notice that timeliness is not there at this point, but these are really intended to evaluate and score data quality that is received from clinical data sources, so EHRs, but it can also address claims and encounters. But the objective is really to classify and score each data source against these 4 dimensions. And then you can, using those scores, start to kind of facilitate how do you improve the data quality and ultimately get it well suited, or best to say, fit for purpose on the usability of that particular data. And really one of the founding fathers, if not the founding father of PIQI, is Charlie Harp, is the CEO of clinical architecture, and he likes to say very succinctly, when you get to quality, you get to usability. So we'll start to touch on in the 5th webinar on how those start to complement each other, both usability and quality. Okay. Thanks, guys. I think we're time for questions, comments, feedback. Maybe before we do that, Margaret, you can tell us what's happening with our poll findings.
Yep, so we got a few responses. It looks like a couple have data owners, a couple of data stewards, and a couple of data administrators. Looks like maybe, yeah, 2 have custodians.
Great. Okay, great. Okay, guys. So let's now go into questions. If there's any questions, certainly feel free to submit them in the, I think it's a question and answer, the raise box. And then if we have others that sneak in, we can follow up. MB, do you have any? You can parlay them over to me if you have any.
I don't see any questions yet.
Yeah,
No.
I don't see any yet, but
Okay.
I'm wondering, the data custodian, I feel like that's sort of a new role that health plans are just starting to understand they need. They may have people that have done that role, but not really in a dedicated role. So be curious to maybe talk about, if we don't have questions, like what do you consider the key responsibilities of the data custodian?
Yeah, actually, that's why I want to kind of maybe go back to that slide, because there's never like a straight line in between all of these different roles. I think of these first 2 roles, like I mentioned, falling into more of a business orientation, whereas the data custodian and administrator kind of falling more into IT. I think custodians are really that interface between what's happening with the business owners and stewards on the business side and the IT. So I think when you're in this role, you probably are coming maybe from an IT perspective, because you would focus on data models. So you have to understand entity and relationships and how those are designed, and really translating maybe business rules into a set of specifications that the IT team can implement. So maybe another analogy would be like a business analyst or systems analyst, perhaps. So I tend to think of this more in a more technical positioning as opposed to the other 2. Okay. Okay, we have a little more time. If there's any questions, please submit them. But I did save a slide because I wanted to share this as well. We'll try not to get too deep into FHIR, but try to hit it where it is here and there. And obviously, it's really the foundational standard for clinical data operations, and that, like I say, it'll kind of play the role of X12, but in the clinical data exchange space. And I wanted to point
Michael?
Yeah.
So Melissa was saying, data quality is a struggle, which I think we all can agree on. And then, qualifying it, like especially across different data types, EHRs, data aggregators, and flat files. And it would be interesting to expand upon the role of data quality with data aggregators, or is that really not part of their role? And does that, become part of the health plan's responsibility because the data aggregator is really setting up the pipes, pulling it all in, putting it in one specific format, and then letting you to figure out kind of what to make of it? But what's your perspective there?
Yeah, what's my take on that? Well, I mean, I will reiterate it again. I mean, data quality, data management, it's everybody's responsibility. So even if you're talking within an organization or across organizations, and I think that's gets to be real clear about governance. Like, how do we share governance across organizations, and what do we expect of your organization internally when you having your own data management and governance? Let me use that actually as to kind of a step off point for what I'm showing here is, part of the challenge with data quality and in enforcing and actually building it in a scalable way is that we have these varying definitions about, what are the definitions of the attributes, what are the definitions, the values that go into those attributes, and we need what I like to call like a lingua franca of data management within healthcare, and that for me is a role that FHIR really serves, because it basically everything can distill to, it's going to come from your own proprietary environments and the mappings, as you mentioned. But if we can converge on this shared layer, and in fact, I met with an analyst recently who called it the audit layer, that FHIR was literally the audit layer. They can get data in CCDs and sending it out in a text file layout. I mean, things may not stay in FHIR, but they need to hit this point somewhere in their life cycle so that we can converge around it, so to say, semantically, and then define a consistent semantic interpretation across both of those environments or multiple environments, and then they can scale out from that. And that's part of the premise of PICI as well, is that we need that standard framework, and then we can score against that standard framework. So I think a practical and a scalable approach to really improving data quality and the complexity that goes with it is somehow understanding where FHIR fits in your architecture, your technology stack, and then make sure you start to bubble out there from, say, a clinical data integration is ideal at that kind of core layer. But if it's happening, say, at the front end as it leaves your provider and it's just mapped to the API and it matches the API, the FHIR API, and then it comes in as FHIR, you have 2 points and make sure those align. And then you're then addressing what's happening pre and post of those translations to FHIR. Okay. Good question. I like questions about data quality, but I appreciate it's not necessarily easy. But this is the approach we're taking, is using FHIR as kind of that core, like I said, lingua franca of data quality. Okay. Other questions, MB?
I don't see any, and I think I'm good. We're also just about at time, so.
Just the time. Okay. Okay, well, let's close it up. We will, you'll have recording of today's session available. It'll be sent out for anybody who's attending today, and of course, anybody who's signed up. Certainly feel free to reach out to us afterward if you have any other questions. And it looks like, Margaret, I think if you have it handy, the schedule of our next webinar should be, I believe it's in January, I believe the second Tuesday of January.
That's correct. I don't have the date in front of me, but we'll make sure to send that out to everybody who's either on the webinar right now or who had signed up for it.
Fantastic. Okay. All right, everyone. Happy holidays. Thanks for joining. Be well, and we'll see you in 2026.
Thank you very much. Well done.
Bye, guys.